Good day and welcome to today's presentation. It's my pleasure to turn the call over to Megan Haupt. Megan, please go ahead.
Great. Good morning. Hope everybody had a great weekend. I'm just going to go over some of the housekeeping pieces. Many of you have heard already, but there may be some new folks on the line today that it might be helpful. So any question and answer, just put in the chat box. And then if you need closed captioning, it is at a button at the bottom of your screen and it says CC closed captioning. You can push that button and get subtitles. There are materials on our website and that link is in the chat box now. That will include PowerPoints and any kind of papers mentioned throughout the presentations. At the end of the day, there will be an opportunity to respond to an evaluation poll of the sessions, and your feedback is really important to us. So that would be great if you could complete that. I am now going to turn this over to Valerie Milkey. Thank you.
Great. Thank you very much, Megan. And good morning, good afternoon to everyone on today's conference day. It's great to have you join us here today. And it really is my distinct pleasure and honor to introduce the next two individuals who are presenting today, both of whom I've worked with and I've known very well, very strong advocates of individuals who are impacted by mental illness and their families, and real strong advocates. And so for our first presenter, it's Kevin Martone. He has over 25 years of experience and is nationally recognized for his expertise in behavioral health. Kevin joined the Technical Assistance Collaborative in 2011 as Director of Behavioral Health before becoming Executive Director in 2012. Prior to joining the TAC, he was the Deputy Commissioner of the New Jersey Department of Human Services. He also served a tenure as President of NASMHPD. And then following Kevin, Rebecca Boss is going to present. Rebecca is the Chief Operating Officer, Vice President of Strategic Development for Kodak Behavioral Healthcare. Rebecca worked for Rhode Island Behavioral Health DDH, I think it's Division of Health, for 15 years and was the director for the last 3.5 years. During her 15 years with Rhode Island, in behavioral health, Rebecca was a highly regarded leader of behavioral health care and developmental disability services with special expertise in addiction and recovery solutions. And so Kevin will present first, and then Rebecca will present second, and then after the two presentations, and then we will open the chat box up for any questions, and then I'll field the questions to the presenters. So Kevin, I'm going to turn the microphone over to you.
All right, great. And I hope everybody can hear me. Thumbs up, maybe. Thank you. And thanks for the introduction, Valerie. It's great to see you and everybody else. And it's good to hear that everybody is pulling this off well virtually. But I'm sure it's sad that everybody is not able to be together, down in DC or wherever this meeting, could be, given the circumstances. So, but it's exciting to be here, and really happy that NASMHPD has taken this initiative on in terms of looking at crisis systems and taking it a step further and looking at across a lot of the more specific issues and challenges that you all and we all experience out in the communities. And so I'm going to run through crisis services for persons who are experiencing homelessness. And talk a little bit about that perspective from a paper that we put together, and then Rebecca will talk about it from the SUD perspective, and we'll jump right into it, and hopefully we have some additional conversation later on. So now, Megan, do I need to share my screen? Is this?
Yes.
Yeah. Right. Good. Okay. All right, good. Here we go. So, this paper focused largely on crisis program provider level issues, but it's really important for all of you to think about how you can ensure that crisis programs are supported to address the needs of people as effectively and efficiently as possible, right? And I think from all the presentations that you've seen over the past several days on crisis programs, you know that. Our crisis programs are very fragmented across the country, and often the first responder in the crisis system is still law enforcement, and particularly for people with behavioral health conditions who are homeless or experiencing substance use disorders. And changing that narrative is bigger than each of the papers individually, but hopefully our presentation today will inform your thinking about supporting crisis programs as we all go forward in this area. Homelessness is in my mind, is largely a failure of housing policy. It's not necessarily a failure of mental health policy. And I think that's really important to keep in the back of your minds. But when I think about homelessness, I really think of it as one of the big three perceived visible failures of the mental health system. And those three big perceived visible failures in my mind are homelessness, incarceration, and institutionalization. And so, we know that the behavioral health system, and more specifically in this context, the crisis programs by default, are often assigned accountability and as you know, the first responder to many of these challenges. And so I just want to sort of put that out there, some of the backdrop for the conversation that we'll go through over the next 25 minutes or so. But generally, and again, a lot of this is, we all know this when we're looking at folks with behavioral health conditions who are also homeless. The numbers are big. I'm not going to necessarily get, the bullet points are up on the screen here. I'm not going to necessarily dive into the weeds of that, but the numbers are big. And, a lot of people who are experiencing homeless have, severe mental illness or other more mild mental health conditions. They also have substance use disorders, as Becky will talk about. They also have chronic health conditions, as we know, and then obviously co-occurring disorders. Those numbers are even more stark for folks who are unsheltered homelessness, and so we have to think about that in our responses and systems. We also know that trauma is very prevalent among individuals who are homeless, and oftentimes, people may become homeless as a result of their trauma, and vice versa. We also know there are the higher prevalence of suicidal ideation and attempts in folks who are experiencing homelessness. And we also know when we're looking at folks who are homeless, there are many people, African Americans, Native Americans, Hispanic and Latina populations that are overrepresented among people experiencing homelessness, in law enforcement, in behavioral health systems and things like that. So, generally, in a nutshell, when we're looking at the background of who makes up this population, it brings together a whole host of issues that we see, and deal with on a regular basis, not only the homelessness, but the poverty and unemployment and all those things. And so just keep that in the backdrop, of your mind when we're talking about these groups. So when we laid out the paper, we followed the SAMHSA guidelines. We address some of the challenges and recommendations and strategies in each of those core areas, the call center responses, the mobile response teams, and the crisis stabilization programs. And so the next couple of slides are going to hit on some of those issues for your information. So, and many of the issues I think that we're going to talk about here are things that you've probably heard over the past several days in crisis programs, but in my mind, when it comes to folks who are homeless, who are experiencing behavioral health conditions, they're even that much more important to consider, just given the complexities of this population. And so we know in crisis call center calls, you're more likely to get calls about people than from people who are experiencing homeless. And that's a big thread that we heard when we were putting the paper together. Just a quick note, when we were putting the paper together, we did some, obviously some research on literature, but we also conducted several interviews of crisis programs across the country to really sort of get that, that direct level feedback for folks. And this was something that really stood out to us, was that, you're more likely to get calls about people who are homeless than calls from people who are homeless. And oftentimes that becomes first responders like law enforcement. It might also be businesses, right? So you may have, the stereotypical scenario where you have a person with mental illness who appears to be homeless, who's loitering in front of a business, for instance, and the business owner, if they have access to a helpline, they may call it. But oftentimes it's law enforcement that calls first. one of the things that we really teased out in some of the conversations, and we know this through our work at TAC, is in that initial call when you're working with, that caller, part of that clinical assessment is really doing a housing assessment and understanding, what is that person's living situation? Where are they living right now? What's going on in their life? Because that really ultimately informs your triage. And I sort of call it the crisis differential diagnosis. And this is really an important part of understanding what is the root of the problem when that call comes in. Is it, someone who is acutely psychotic, or is it someone who's really struggling with homeless and everything that goes around with that, that is sort of precipitating or may actually be the total crisis. And so those are really important things to tease out, particularly for this homeless population when those initial calls come in. It's also really important for the behavioral health system to have knowledge of the homeless system and social services system for this specific population. Oftentimes that call that may come in may not necessarily be a real psychiatric crisis, but nevertheless, the call center or even mobile will have to respond to it in some way. And oftentimes a resolution to that crisis may be really linking a person up with housing or other social services that can help mitigate what's going on for that person in the crisis. And that's a really critical component. And I'll tease that out a little bit more in some of the slides as we go on. And that just sort of gets you to, in that assessment and triage process, as you understand what the root of the problem is or the call, it's then, making that decision tree, if it's really a social services issue, really having those good resources at hand so you can make good, warm handoffs to the right types of services for folks. When we took a look at mobile response strategies and considerations, we tease that out a little bit further, right? So what came out of the initial call? And as you sort of see a mobile team responding out there, that engagement is really critical, and that crisis differential diagnosis comes into play here too. Many times individuals who are homeless with behavioral health conditions for a wide range of reasons are less willing or more reluctant to engage with responders, whether those are crisis responders or law enforcement or whatever. And you really have to think from a mobile perspective, how are you going to engage that individual? And we saw and heard from all of our calls and the research that, some of those clinical interviewing practices that we've all become familiar with certainly apply. Motivational interviewing, being trauma-informed, being culturally responsive, all are critically important. But the basics are really important with this population. Understanding what the problem is, offering food, helping a person get out of the elements, even if it's just to do the clinical interview and assessment with the person, are so important to engaging a person who may be experiencing a behavioral health condition and who's living on the streets. And as mobile teams are out there, one of the things that we saw and heard clearly, you think about a person who may literally have nothing except for, some personal belongings or a pet and things like that. Those are things that are so important to a person who's homeless, who's going through this type of crisis. And it's really critical that the mobile teams, understand that and have strategies to work with an individual on being sensitive to their belongings and even ultimately thinking about how you're going to manage those belongings or pets or, for instance, with that person during the crisis, certainly if a person has to go to the next stop, which might be the crisis stabilization facility or even an inpatient unit, for instance. We also thought it was important in the paper to really talk about responding to encampments, and those are formal and informal types of settings. And on the informal type of settings, it's really important for mobile teams to understand the situations and scenarios that they're going into. Sometimes those informal encampments may have their own public health or sanitary issues that come up. Some of those places may have their own informal or formal rules that are in place about visitors coming in. And so, mobile teams have to really consider that when they're going out to respond to homeless settings, that they're considering a whole range of scenarios that they might be encountering when they go out there. And this is important in all facets of crisis, and I'm sure that you've heard this in all your other settings, but it's obviously critical to incorporate people with lived experience into crisis programs. And I think the point I want to emphasize here is often in the mental health field, we talk about the importance of bringing in peers with lived experience with mental illness and/or substance use disorders, and that's obviously critical. But it's also really important to consider bringing in people with lived experience on the homelessness side. And if you're in the homelessness world and you're working in homelessness providers and things like that, lived experience with homelessness is very important in that world too. And so, obviously, unfortunately, those folks exist out there, but it is critical nonetheless to have those people with that experience on your crisis teams in all of these settings. As we think about crisis stabilization considerations, again, we want to sort of take it a step further. And this is something that we saw was, it was different in different parts of the country or some of the interviews that we had. And how does homelessness factor into the need for crisis stabilization and maybe a step further crisis residential services, right? And so when you think about sort of the core responsibilities of crisis programs being, to address the psychiatric crisis that may exist, homelessness adds this whole other level of complexity that crisis programs often deal with. In what is their role and responsibility in addressing the person's housing situation. The long-term crisis programs just don't typically engage people long enough to address permanently the housing crisis. But nevertheless, that role with the crisis team could be really important as a first step or stop in helping to address that person's homelessness, even if it's getting that person into a crisis stabilization setting for a couple hours or a day. Or maybe sort of the next stop, a crisis residential program for a couple of days, and not necessarily to permanently address the housing situation, but it is a core step along the way to maybe engaging that person into a more permanent or longer term housing setting. And crisis programs really need to sort of think about their role and responsibilities there. We heard that in some of the programs, they had the capacity to sort of take on that responsibility and push it out a little bit further. And other programs really were sort of, clear that their role was to sort of address that immediate crisis. And then they just didn't have the capacity to go beyond that. Similarly to the mobile response strategies, managing personal belongings for this population, for folks who are coming into a crisis stabilization program or crisis residential is really, really important. If there is not a plan to address those, the ability or willingness of a person to want to go to one of those settings is significantly compromised. Again, bringing peers or consumers with lived experience into crisis stabilization programs as staff is critically important, and we saw that in several of what we thought were better performing crisis programs in the country. It's also important to consider providing an opportunity to stabilize the behavioral health crisis and begin linkage to housing and other supports in this type of modality, right? So mobile, it's a little bit more challenging to do that. Crisis stabilization, even though it's short term, you may have a little bit more of an opportunity to help with those linkages to some of these core supports and housing services. And I think the key here is, again, you're probably not going to solve the permanent housing issue, but it's really important for crisis stabilization programs and certainly crisis residential, a next step if you have that, for the staff to move with urgency in that transition planning. Again, because the time that you have with the person is relatively short. And, with this population, those linkages to the next stop are critically important because of some of the challenges with engaging them. And if you lose that opportunity, and you may not see that person again until they encounter the deep end of the system. So working with the homelessness system is definitely something that crisis stabilization or crisis programs in general, I think, need to improve upon. In most parts of the country, the mental health and homelessness system operate very distinctly from each other. Crisis programs really should know and understand the formal and informal homeless systems in their communities. And oftentimes this is best learned from the homelessness system, right? And it's really having those conversations and partnering with them about what their homelessness system looks like, how it's shaped, so that the crisis programs can really fully understand all the components of that homelessness system. And on the flip side, it's really critically important for the crisis system or the behavioral health system to be really clear with the homelessness system about the roles and responsibilities and limitations of what behavioral health and crisis programs can do, so that everybody's on the same page. Really, really important. The other thing to keep in mind is that the homelessness system will often have some fairly decent information on people who are homeless. Much of that information, many of you know, if you're not, it's important to know, may be in the Homeless Management Information System, or HMIS, if you've heard that. And that's really a HUD required tracking system for people who are homeless in local communities, in order for those local continuums of care to receive federal HUD funding. And in several systems across the country, you see some of that data sharing going on between a behavioral health system and the homelessness system locally. It's generally done at a local level. There are some state experiences, and this may be happening in some of your states. And certainly, we've seen scenarios at the systems level where Medicaid agencies are working with homeless HMIS systems to do data sharing agreements to inform how Medicaid services are covering housing-related services for people who are homeless. So it's really, really, really important to think about those data sharing strategies. And ultimately, we talk about this in the paper a little bit, is ensuring that there are formalized partnerships between the homeless system and the behavioral health crisis provider locally in the system, so that you can really address these cross-cutting, cross-system issues that come up, in terms of warm handoffs and discharge planning processes and access to shelters and all of those things. They really are distinct systems, and those formalized relationships are really, really important. Similarly, on the law enforcement side, we talked a little bit about training and data sharing and things like that with law enforcement. As I mentioned earlier, the law enforcement's obviously the first encounter for many folks who are homeless with behavioral health conditions. And this is just a really, really critical piece out there. Quick story I want to share from my experience when I was in New Jersey. And Valerie can appreciate this. Our old building in New Jersey on the second floor was basically a big food court, and a lot of folks who are homeless used to hang out there during the day. And I was coming up from another building and came onto the floor one day, and there was a gentleman who I'd known to be homeless. He clearly had schizophrenia. He'd hang outside the building often, and he was sitting on the landing in the building smoking a cigarette on the floor. And when I walked in, there was a policeman standing over him, talking to him, telling me he's got to drop the cigarette. As I'm standing there watching this, two fire trucks pull up. Next thing I know, there's 3 or 4 firemen who walk into the building. They're standing over this guy, and he's smoking a cigarette. And I'm watching this to see how this plays out. And this guy wasn't dropping the cigarette. And finally, the police officer reached down to grab him, to pick him up. He resisted. And you know where this is going. He's going to end up in handcuffs, best case scenario, and go to the jail, probably not the emergency department. And at that point, I stepped in. I said, hold on a second. And the cop was like, who the hell are you? Excuse my language. But in any case, I said who I was, and I was watching the situation. I said, can we handle this a little bit differently? I said, and when he realized who I was, he took a step back, and we talked about it a little bit. And I said to the guy, and he had seen me before because I just seen him outside the building a lot. And I said, what's going on? I said, are you hungry? And he nodded his head yes. And I said, do you want a piece of pizza? And he nodded his head yes. And I said to the officer, I said, if I give this guy a piece of pizza, can this situation be resolved and go away? And he's like, okay. And long story short, that's what happened. Okay. I walked him upstairs. We got him a piece of pizza. He walked outside. We had a talk, and that was it. And I think the point of that was there were a lot of things that went wrong in the system right there. I mean, clearly, the police officer didn't necessarily have an understanding that there was a mobile team in the area that could respond to that. As could have the local PATH team, I know, who was frequented the building a lot. The law enforcement officer didn't really try to understand the situation. It was really one of those comply with me or else you're going to jail in cuffs. And minimally to me, that police officer really needed training, and support, as did the fire department, on sort of what are the issues going on with this gentleman. He was known to be a homeless guy in the area. And at the end of the day, he wasn't psychotic. I mean, he was psychotic, but he wasn't acutely psychotic. He wasn't a danger to himself or others. He was hungry and he needed some food to eat. And I think that's just a really sort of good example in my mind of sort of how we really need to make sure that these systems can come together so that they're aware of each other and they can work better at each other, to improve the types of outcomes that, or at least avoid the negative outcomes that almost could have happened there. And, when you think about the number of officers in a department, this was in the city of Trenton, and how much they deal with on a daily basis, you could understand the challenges with that. And so I think the takeaway here is that, the ability of crisis programs, and law enforcement to work together on all of these issues, and particularly for the homeless population, is a really big deal, and it's really labor intensive, and it requires a lot of attention and nurturing. So I sort of alluded to these issues and just want to summarize, when we're talking about training topics that may be applicable to your crisis program workers, obviously it's training on, those core clinical types of interventions. And I'm assuming that you've all talked about those, motivational interviewing, trauma-informed care, et cetera, et cetera. But a lot of times for this homeless population, it's training your crisis workers on some of these key logistical issues, right? What is the homeless system and what's it all about? The formal and informal homeless system. How is the law enforcement working in your community? And again, as you know, that may be several different police departments that the crisis programs are having to work with. Even within a city, it might be different precincts, or if it's in a county, it might be several different police departments. And that's a really hard lift, but those folks need training on all those issues. Training on the social services components and the portals or access into social services is absolutely critical for the homeless population, because many times those crises can be mitigated or resolved, with warm handoffs to social services. They're not necessarily solutions, but it really can facilitate a resolution to the crisis. And same with housing resources. Again, the crisis programs may not be able to permanently solve the housing problems for these individuals, but having an awareness of the different types of housing resources that exist in a community, even if it's temporary, transitional, shelter-based, or whatever, can really go a long way in helping to resolve that crisis. And I also think it's important for crisis providers to know these local issues about the homeless system. Where are the encampments? Are they formal? Are they informal? What are the local homeless policies and or ordinances that may exist in your community? Are there policies on loitering? Are there laws on sleeping in cars and parking lots? So that when you get a call, you're as able as possible to be able to respond, with that localized knowledge that's so important. A couple of things on the pandemic that we thought were important to weave into the paper and bring out. And again, this is probably not foreign to you, but we know we have heard decreased provider contact out there. And at the same time, we know with the economic impact out there that we are likely to see increased homelessness out there. And that may then mean more crisis system encounters. Now, there's a lot of housing resources that were authorized in the CARES Act, which is good. That's going to take some time to get out on the street for folks. So we do anticipate we're going to see crisis programs are going to see more encounters with folks who are homeless and experiencing behavioral health conditions. Mobile programs, obviously, as programs all over, are struggling with PPE. With this population, access to telebehavioral health populations may be more limited. People flat out don't have phones all the time, and that's really a challenge. Obviously, mobile programs and crisis stabilization facilities will have to deal with universal precautions. We have heard of and seen decreased capacity in crisis stabilization and crisis residential programs due to local physical distancing requirements, which can impact capacity, obviously. Many local systems have established hotels for quarantine and temporary housing for homeless populations, and it's really important for crisis programs to become familiar with those programs, the providers who are running them, and the rules and requirements around them, because you may be responding to those types of such situations. And obviously, the state budget impact, I'm not going to spend a lot of time on this. You guys are aware of the challenges ahead of us on that, and that will have potentially an adverse impact on crisis programs. And then I'll finish up on takeaways quickly. Understanding the crisis with an individual is really important. What's the foundation, right? Is it an acute psychiatric illness? Is it that the person is homeless and exposed to the elements and hungry and starving and hasn't showered in 2 weeks? If you can imagine what that is. But understanding that is really critical to a successful resolution. One of the things that we heard from the programs was the importance of making a quick disposition or an extended engagement. And I think the programs that we've talked to ideally favored trying to have that extended engagement within reason, right? We're not talking weeks or months, but to be able to make the appropriate engagement and linkages to the right types of services for these folks who have really complex challenges. Cross-system and clinical training is really important for this population. those relationships with homelessness systems and first responders, obviously critically important. You know, we touched a little bit on the paper in terms of those first calls. Where do those first calls go? And that is still a challenge, I think, in many systems, with 911 or non-police emergency lines being the first call for this population, and some of the negative consequences for that. You know, again, the importance of training and developing those relationships with law enforcement and first responders are critical. Structural racism, I think, is a really important concept and challenge for this population. You know, we know that many people who are homeless because of some of the structural racism issues that exist in the system out there. And, you know, it's important for the crisis responders to be fully aware of those issues. You're not necessarily going to solve the structural racism, but it's really important to be culturally and ethnically responsive when you're engaging folks who are homeless. We talked about, with the pandemic, obviously more and more people may be encountering crisis services as we go forward. And I think, you know, one thing as you sort of take away here with funding, and I'm sure you heard the importance of funding capacity and crisis services in all the presentations that you may have previously had. But with this population, I really want to drive home the need to ensure that you're funding capacity for partnership, development, maintenance, you know, with the homelessness system, with law enforcement, because it is labor intensive. It's a big deal, and it will go a long way in successfully working with individuals who are homeless and having behavioral health conditions. So I'm up on my time. I'm going to pause there and turn it over to Rebecca, and can answer questions at the end if needed. So, Rebecca.
There we go. Thank you. Well, it's a pleasure to be here this afternoon, and I thank Brian and the team at NASMHPD for including me and providing this opportunity. And I thank Kevin and the team at TAC as well for inviting me to engage in this paper and being able to present to you today. And it's wonderful to see the names and faces of some of my fellow commissioners and SSAs from the past, and being able to be here and say, yes, there is life after state service. You can look well and relaxed and rested sometime in the near future or in the distant future, depending upon what you choose. But it is really wonderful to be here today and talk about the topic of substance use disorder as it relates to crisis response. And many of you, if you know me, know that I, as Valerie said, I have been a strong advocate for the care of individuals with substance use disorders as well as mental illness, and for integrated care. And truthfully, we have been talking about integrating care for people living with mental illness and substance use disorders for a very long time. If you look back to the 90s and the early 2000s, there was a lot of work that was going around co-occurring disorders and providing integrated treatment. And then as we started to talk about integration of behavioral health and physical health, it seemed like some of that work just dissipated. Some states, some programs have been very strong in continuing the work and providing good integrated care for co-occurring disorders, and others, you know, maybe less so. And so, you know, the prevalence of substance use disorders as well as co-occurring disorders nationally really require that we pay attention to substance use as it relates to crisis response. And I would say that we know that 99.1% of those with co-occurring disorders receive treatment for both. It's really unclear what percentage of individuals responded to while in crisis have interventions that are substance use disorder informed. And it's important to note, and that's the reason why I put it on the slide in such a big way, is that, you know, a lot of individuals with substance use disorders that need treatment don't think that they do. They don't perceive that there's a problem. So I believe that moments of crisis really present us an opportunity to aid individuals to see the impact of unaddressed substance use disorders, provide faith that treatment can be effective, and help them start to believe that recovery is possible. And crisis provides us with that opportunity to reach individuals. And it's really important as crisis providers that we know effective engagement requires the absence of prejudicial attitudes and discriminatory practices. So masked or hidden beliefs that substance use is a choice, or that people don't really want to get better or could stop using if they really wanted to, really needs to be addressed, because it will defeat all of our efforts. And if we engage the substance use disorder population, we want to make sure that our policies are designed to reduce barriers, and that we're working with our staff to address what their belief system is around substance use disorders and work towards effective engagement strategies. I can't seem to forward the slide. Oh, there we go. So I started off with COVID-19 issues in relation to substance use disorder and crisis because really this is the perfect storm. If we think about the epidemic within the pandemic, this is a population that we need to pay attention to, especially in crisis. So the risks are real for both susceptibility to the disease and negative outcomes, and increased risks associated with substance use disorders, including overdose. And in fact, we've seen an increase in overdose in many states across the country during the COVID-19 crisis. So what do we know? We know that social isolation presents real challenges for individuals in many stages of recovery, early recovery, later recovery even. So, and we also know that individuals are likely, because of social isolation, to be using alone at a time when outreach workers' efforts have been decreased because of, or curtailed as a result of the need for social isolation. And access to treatment may be limited. It's especially important to be aware of the real-time access connection to interim services if there are waiting lists. We know that alcohol sales have skyrocketed during COVID-19. We know that reports of intimate partner violence have increased as well, and the connection between alcohol and intimate partner violence. So crisis responders may very well see significant increases in need, different populations that maybe they haven't seen as much in the past, at the same time as we're seeing decreased resources. So it's important that we recognize the importance of the crisis response system as the epidemic and pandemic coexist. So if we look at the call center considerations and look at some of the information that we know, that there's a connection between substance use, especially alcohol, and opioid and suicide risk. And it requires that, as we respond to calls in the community, the responders are aware of this, are screening for these kind of issues, and that we are paying attention to these risk factors associated with the substance use. We look at SAMHSA's requirements of what a call center should be. We need a workforce of clinicians and trained team members to oversee triage, answer all calls, assess that suicide risk, and then connect individuals to mobile crisis team as well as facility-based care if indicated. So we need to look too at training specific to substance use. Do we know whether or not the person is at risk of overdose? Do we know whether or not we need to have medical intervention for withdrawal related to alcohol or benzodiazepine use? Will a mobile crisis team need to be accompanied? Are they okay on their own? Can the individual be sustained where they are with support and connection? These are all the questions that are really critical as we talk with individuals who are reaching out to us, or the individuals or family members or other individuals who are reaching out on behalf of someone concerned with, the questions we need to answer, to get answered in order to be able to put together an appropriate response. Many states have developed substance use disorder specific crisis call lines. And a lot of times when individuals are calling a crisis line for substance use specific issues, they already have a defined desire to decrease or discontinue their use of alcohol or other drugs, but they can't seem to navigate the treatment system that seems complex. They don't know where they should go, where they belong. They don't know what the real-time access to those systems are. And so states such as Indiana, Tennessee, have created hotlines and many others for individuals that are crisis lines, and individuals in crisis, their family wants them to get treatment. And it really helps them to connect somebody to real-time treatment availability, understanding what the best treatment may be to meet their need, helping them with a warm handoff. Tennessee connects the individuals that call to individuals who are in recovery themselves, while on the call, all in real time, and giving that individual the opportunity to be connected to the care that they need. It's really striking while the iron is hot, and individuals in crisis with substance use disorders get the assistance, and not just well, you can call here tomorrow, or if you show up, we can help you, is really important. And then with mobile crisis team response, we see that there have been differing capabilities of mobile crisis teams in order to be able to respond to substance use. Many of the development focused around mental illness specifically. And mobile crisis teams are really uniquely positioned to impact response to substance use disorders in the community. Appropriate screening and assessment can inform the response. We need to know whether or not mobile crisis teams need to be accompanied by law enforcement or medical intervention in the community. In response to the overdose crisis and the opioid crisis, a lot of co-responder programs have been established in states with a concerted effort of outreaching to a substance use disordered population post-overdose. So individuals who have been treated are seen or followed up on the next day, whether it's a clinician and a peer responding with law enforcement or emergency management, to individuals, to their families to provide support. Well, not necessarily in the midst of the crisis, using crisis as an opportunity to respond and provide connection, to help individuals access care, to see where they are, to provide naloxone, to provide connection to recovery supports. A lot of states have really been creative in their opportunities to engage people with substance use disorders during the crisis, but then also post the crisis in the community and not waiting for the next crisis to occur for the individual to show up again. Crisis stabilization centers, like call centers, can have an opportunity to really positively impact individuals with co-occurring disorders or substance use disorders. Engagement with individuals is critical with substance use disorders, and understanding the changes theory, stages of changes, and using evidence-based approaches. I know Kevin mentioned motivational interviewing, but really being able to meet the individual where they are, both literally and figuratively, is really important in engagement strategies with a substance use disorder population. Stabilization centers that can offer immediate or near immediate access to the assessed level of care, including induction on medication or detoxification, really have an opportunity to create that impact at the moment when it's needed. And engaging peers with lived experience with substance use disorders can give individuals who have been feeling helpless for a very long time a glimmer of hope for recovery, and understanding that, seeing somebody when you're in the midst of crisis who's been where you are and can tell you that there is an opportunity for you to live a different life, to have a successful resolution of the crisis, and be able to see that that opportunity is real in a crisis situation is really impactful for this population. Also understanding, how to treat, again, co-occurring disorders, and understanding when individuals are presenting that maybe can be connected to the right level of care, and understanding the impact of the substance on the mental illness, and offering the kind of services that are needed in the moment. And I'm getting, I'm sorry, I'm rambling a little bit, and I don't mean to ramble a little bit, but I really feel that crisis stabilization centers have an opportunity to engage individuals in ways that will have a long-lasting impact. And it's important not to minimize the engagement strategies that we use with individuals, and to understand where they are and being able to meet them. The SAMHSA guidelines that were recently published looked at some of the core principles, and one of those core principles was addressing recovery needs. With individuals with substance use disorders and those with co-occurring disorders, the fact that recovery is possible is sometimes an elusive concept. And it's difficult for individuals in the midst of substance use disease as being able to believe that recovery is possible for them. There's been a lot of talk about recovery capital and understanding what individuals need in order, once they've attained some kind of sobriety or abstinence from substances, the recovery capital needed in order to engage in a meaningful and full recovery includes a lot of elements, and housing is one of them. And Kevin talked about the impact of homelessness on the population. We know that employment and recovery supports and other individuals, and having meaningful engagement with others is really important. And in crisis response, knowing that individuals, where their strengths are, what are the recovery capital that they have, what are the gaps, what do we need to address, is very critical in terms of looking at the longer term impact for individuals that we engage in a crisis. And I think it's also important when we look at that individuals who can choose to engage in recovery, that choice to engage is desirable, but treatment initiated due to legal or other feared consequences is also effective. And so a lot of people with substance use disorders, like in the homeless system, their point of engagement is with law enforcement. It's law enforcement, it may be the emergency department, but we know that a number of the individuals who are in our correctional institutions have substance use disorders that has been inadequately or untreated for a long time. And the point of engagement with law enforcement, and when we look at drug courts versus, say, mental health courts, these are criminal charges. So individuals who are entering the system oftentimes are entering as a result of contact with law enforcement. And it's important to know that law enforcement, if we use the pressure of law enforcement and criminal charges and some of the pressures related to legal involvement, can be very effective. And a lot of old thinking has been, people can only get better when they want it or only when they're ready. But those that know the stages of change theory and know how to engage individuals who may not necessarily see that they are ready or want something, the pressures that that have been impacted by law and legal consequences and family and others is really part of how do we use that to engage individuals in the treatment system. I look at some police departments, Tucson Police Department invested grant funding for comprehensive training in motivational interviewing and trauma-informed care. And that empowers the officers to engage individuals in midst of substance use disorder, in the midst of crisis, in making decisions that can be recovery oriented. And knowing the recovery needs and the support of individuals and how to engage them in care is really part of being an effective response. There's a significant role for peers in crisis response for individuals with substance use disorders. Despite the fact that the 12 Steps programs have supported sponsors and a real connection to individuals in recovery throughout the 12-step program, really certified peer recovery specialists are a relatively new development in treatment in the recovery world. And there has been and continues to be some division amongst peers defined as having either mental health or substance use disorder lived experience. I think we're beginning to blur those lines, but it's really in its early stages of the ability to do so. And certified peer recovery specialists are really different than sponsors through 12-step programs, and they play a different role. And peers have been used in outreach strategies and programs in overdose response, in engaging with individuals in the community, as well as using peers to respond in crisis systems, whether it's in the crisis stabilization systems or as part of mobile crisis teams. And we look at ways that states have engaged peers in response in different settings. So many states have had peers going into emergency departments to meet with individuals who have survived an overdose or individuals who are coming in and have been engaged in emergency department as a result of alcohol or other substance use. And then we look at peers who have been able to reach out to individuals in correctional facilities or primary care settings or community-based settings, and thinking about the expanded role of peers not only in crisis response but pre-crisis as an opportunity to engage individuals to make decisions for recovery is really something that has come a long way. A lot of states are really doing innovative work, and I have to say that it was really a pleasure having an opportunity to talk to many of my former colleagues and commissioners and SSAs and looking at this information, because there's some really innovative work going on out there across the different states and systems. Essential partnerships in response to substance use disorder in a crisis system may be a little bit different than what we normally think of. We think about crisis systems oftentimes as ED diversions, but really for substance use disorder, EDs, emergency departments, can be a place of engagement, and using the opportunity that presents with an emergency department to be part of a crisis response team is important. We know that in EDs, many visits are related to trauma, and many of those trauma visits are related to alcohol use or opioid use. There's been success in emergency departments in implementing screening, brief intervention, referral to treatment, SBIRT, as an opportunity to identify and engage individuals in earlier stages and to bring in professionals and connect people to care that gets people beyond the emergency room and connected in the community. We also look at treatment initiation as a possibility in the emergency department. Many emergency departments have begun initiation of medication-assisted treatment for opioid use disorder. Inducting people on methadone or buprenorphine with a connection to a warm handoff to the treatment on the community has really found opportunity to reduce overdose rates in many communities. If you look at California, the Bridge program does both. They have the opportunity to provide buprenorphine and embeds recovery support navigators within the emergency departments that can follow up post the emergency department engagement. And emergency departments have become critical partners that are thinking differently. And when we look at engagement of recovery support staff within the emergency departments, we've seen culture shifts within how people are related to when they arrive, when they have substance use disorders, when they're in crisis, and a higher rate of individuals being referred to treatment, even in the absence of recovery support professionals from the ED staff themselves and existed prior to that. We also look at relationships formed with first responders as crisis partners. You know, first responders have been out there in the field for a long time, and as noted with the presentation on homelessness with substance use disorders, are also the folks that show up first to the scene for individuals who are in crisis. Whether it's alcohol or opioids, we know that our first responders can be effective partners in reaching populations if it's appropriate to implement emergency department diversion and responding to individuals, but also to be present in the community. And many communities have implemented something like safe stations models where individuals can show up at any time of day or night and be responded to by EMTs who can assess vital signs and determine the appropriate next level of care for an individual who really wants treatment. I know in Rhode Island, our first responders have been active partners in substance use in our overdose task force in looking at ways that they can come to the table and be part of the response. We've also had emergency departments come to us and say, we want to be a better response in terms of the COVID response. And we know that people are isolated, may not have access to telehealth. We can help, and we can use our ability to connect individuals using telehealth equipment that we have, whether it's to the crisis intervention, the stabilization center, or if it's triage, or if it's just even providing induction in the community. First responders want to be part of the solution during COVID, and then post-COVID opportunity abounds for really capitalizing on that relationship that's been formed with first responders. And law enforcement partnerships have been crucial as well. And law enforcement has done a lot of work in response to the opioid crisis and looking at their role in engaging people in the community. Law enforcement arrest diversion programs abound, and we have, ride-along programs now engaging people as peers with substance use, lived experience, or clinicians with law enforcement that are responding to individuals in hotspots or going out and, making contact with individuals, trying to avoid the arrest and get individuals engaged in programs. In Rhode Island, we have a law enforcement program called the HOPE Initiative that's engaging with peers where they distribute naloxone and fentanyl test strips and, engaging with individuals with a different hat on than has been experienced in the past. But I think that the opportunity for law enforcement partnerships hasn't necessarily been looked at in a substance use specific focus for a long time. And it's really coming around now in ways that it has not in the past. So financing strategies, it really described well in the SAMHSA, the guidance that was provided recently. And looking at braided funding, the use of block grants, discretionary grants, and Medicaid reimbursements to support community crisis is important. We know that strict reimbursement is not likely to provide the support needed to respond to crisis in the community, and we need all kinds of funding to support the critical work that's done in that community. SAMHSA identifies, the existence of braided funding in the guideline, but it's really important too for sustainability purposes that we do engage our Medicaid and our commercial reimbursement structures to support the clinical work that's done as part of crisis assessment, as part of crisis response, whether it's in mobile crisis teams or it's in the crisis stabilization centers. We need to have the opportunity to have effective reimbursement structures in place. And I would say that with the advent of the opioid crisis and crisis response using, looking at substance use disorder specifically, the Substance Abuse Prevention Treatment Block Grant is something else that we can look at in terms of supporting the structure of our crisis response system in ways that perhaps we haven't looked at it in the past. And I would say that key takeaways is that, it's really hard to support a disparate system of care in crisis or anywhere else when it comes to behavioral health. Mental illness and substance use are need to be responded to equally in our communities. We can't expect systems to be different based on diagnosis. Incorporating substance use disorder meaningfully into crisis response really means training of staff on all levels, and training on substance use specific issues and assessments of individuals in crisis related to alcohol or opioids, but also use of evidence-based tools like motivational interviewing and recognizing stages of change and how to engage individuals effectively. Engaging individuals who live substance use disorder experience is really important. We know that some states have struggled with that because it's taken a while to build up a cadre of certified peer recovery specialists with SUD lived experience. I think that the area of certified peer recovery specialists with mental illness has been much stronger with a more significant history behind it. And we're playing a little bit of catch up when it comes to bringing individuals on board with lived experience with substance use disorders. And access to real-time treatment, whether it's detoxification, withdrawal management, or medications to treat opioid use disorder or other substance use disorders is critical. And being able to really take a look at our staff, examining any attitudes that may exist that would be prejudicial or discriminatory in any of our practices that may provide barriers to individuals with substance use disorders from effectively accessing the right level of care is really important to do, not only initially but ongoing, to make sure that we're not putting anything in the way of effective crisis response. Engaging partners outside of what we normally would have in a crisis response system, including our hospital systems, healthcare providers, law enforcement, EMS, our peer-based recovery organizations, recovery centers. They all have a role to play in substance use disorder throughout the continuum, including crisis care. And being able to engage those partners in our response and being open to new partnerships is really important as we progress to address substance use disorders. And the final point I would make is it's just a note. And I think for a long time, and I'm criticizing my own field, but substance use treatment providers have been on the back burner or in the background for a long time. They haven't necessarily been at the table in some really important discussions. Whether that was their own doing or whether they were being left out is up for discussion. But it can no longer be a system that sits back and waits for people to be referred to it. Substance use treatment providers need to be on the forefront, making their connections known, being able to be partners in a crisis system, being able to respond with them, and not just say, well, we've got an appointment next Tuesday, or we've got a waiting list, and so we really can't do anything to help someone. are no longer acceptable answers. And a substance use treatment system that can engage with providers that are willing to come to the table and come up with solutions and improve access to care with our crisis system hand in hand, as well as the other partners in our system, is, it's really, time has come. And we haven't done a good job of it in the past. And I speak for that globally. And I know that there are providers that have, and I know that there are some states that have done much more significant work in making that happen. But it's time for us to look at it on a national basis. And a lot of it has to do with some of the prejudicial attitudes that have existed in a long time. And I hate to use the word stigma, but I will. And looking at stigma as it comes to our response to individuals in crisis and throughout the continuum is really important as we go forward. So I thank you for the opportunity to present on this issue. I really am impressed by the work that is going on in a lot of states and a lot of the changes that have been made to increase encompassing substance use disorders in our crisis response. And the ability for us to move forward is really part of what this discussion is about, and being able to have this discussion amongst ourselves and to look at our systems really openly and take away where we have been strong and where we have had some gaps in our care, and what we can do better. And I really am, again, grateful to NASHPD and grateful to TAC for the willingness to have this conversation. And it was really wonderful to see the SAMHSA guidelines that were recently published truly call out and identify substance use disorders as part of the behavioral health care that needs to be addressed in the crisis response system. And with that, I will stop. And I know that Kevin and I and Valerie are willing and able to take any questions.
Great. Thank you so very much, Kevin and Rebecca, for the presentations. Your information really has been very engaging, and a number of questions are coming through privately, and individuals who want to even comment on some of the information that you've shared. So I'll go through some of the questions, but we have a number of them. So we'll try to make best use of the next 15 minutes. First is actually a question from myself. I think primarily to you, Kevin, but also to you, Rebecca, as well. Thought about it, Rebecca, as you were talking about COVID-19. And so, Kevin, one of the points that you made is that, individuals who are homeless, you're more than likely hearing about them rather than them reaching out for services directly to providers. And so as we are preparing for a potential next surge of COVID-19, just want to talk about, see if either of you have any suggestions or strategies in terms of working with individuals who are homeless. One of the things that we've heard both on the addiction side of the house and mental health side is that telehealth was really helpful and beneficial to keep people connected to treatment. But I think individuals who are homeless tend not to have access to telephones. And so, certainly there have been some advocacy around that, but just want to see if you have any thoughts around that and things that we can think about in preparation for a second surge.
Yeah, thanks, Val. Telehealth in the pandemic really accelerated our use of telehealth in the behavioral health field, right? When I think about folks who are homeless and not having access to cell phones and things like that, it's a potential problem. And at the end of the day, I think we need to look at it from a big picture perspective. It's a relatively minor investment that could yield some big returns, for folks by having access to phones, whether it's from a crisis perspective or just accessing their behavioral health or primary health care providers, or even just social services. There is the Lifeline program out there that can make available, phones and low-cost plans. There are some managed care companies across the country who are sort of working with individuals and taking advantage of that, as well as, some managed care plans that are just, looking at it from that perspective and getting phones into people's hands. as well as some behavioral health providers that I'm aware of in a couple of states that are saying, let's get some phones into people's hands. It's going to pay off in the long run. And so I think we need to think that way. One of the challenges that comes up then is, well, folks who are homeless, particularly unsheltered homeless, who are, don't have places to store things, does it become an issue? But I think we need to think collectively with the homeless services community about how we can handle that, right? So if a person is at risk of losing their phone or having it stolen or things like that, how can we come up with arrangements maybe to store that phone, at a shelter or a behavioral health provider during the day, when, and then when the person really needs access, they can use it, and then they can use it for telehealth or self-advocacy with other resources and things like that. But, I think there are ways that we have to think as a field, how can we first pay for it? And I think there's strategies like the Lifeline program or managed care or general fund type dollars. And then how can we help people, protect it and make sure that that equipment is safe? And then I think there's sort of a third, like almost a training and education component to homeless providers as well as the individuals. Hey, here's a phone, use it when you need it, right? And that may not necessarily be the crisis line, but if we provide education to them about how they can use that phone to access the resources they need, it may be the warm line, right? And so I think those are the strategies to sort of build in for folks, let them know that this is not only a tool that can be used, but should be encouraged to use it when they really need it.
And can extend beyond crisis. So, we have, in my organization, provided over 300 phones preloaded with Zoom so the telehealth capacity is real to the individuals that we serve, and have gotten feedback that a lot of the patients really feel empowered. This is the first time that they've had this, and now they have access to what the rest of the world has had for a really long time. And giving them that opportunity allows us to access them through telehealth, but also allows them to access other services that you and I normally do when we look at our phones.
Thank you very much for that. So we have a question that came in for you, Kevin, regarding children, families, crisis, and homelessness. Just want to know if you have any specific recommendations when addressing children and families who are in crisis.
Well, sometimes you see in systems you have separate crisis programs for children and families, right? So, it's important to know what exists in your system, if it's a separate crisis response program or if it's through the more traditional adult crisis program. I think that's the first thing to consider. When dealing with the homelessness system on that, there are homeless providers, and, there may be different shelters for children and families or youth homelessness, that the crisis programs would need to become familiar with. HUD right now, U.S. Department of Housing and Urban Development, for the past several years has been making a pretty big effort at addressing youth homelessness. And there have been a lot of HUD dollars that have gone to youth homelessness planning and interventions in many of the cities across the country. So that's definitely something to take a look at. And again, if it's not one of your communities in one of your states that's receiving one of these HUD planning grants, it is worth taking a look at some of the interventions that they have been addressing from the homelessness side to get children and families engaged in housing. And sometimes that's youth housing programs, rapid rehousing programs, and things like that. But I think at a basic level, I think it's important to know, how is your crisis response system structured for youth and families? If it's different, how can those programs work together? Because that call may come into the adult line when it's really youth and family line, and those systems have to come together. And obviously, I don't want to, get into the weeds too much, but, you also have child protective services and education as well that may be systems that need to be brought into it, even from a homelessness perspective.
Great. Thank you, Kevin. And Rebecca, a question for you. How do we do a better job of connecting individuals post-crisis to increase the opportunity for engagement?
The importance of peers can't be understated, and the ability for peers to provide a warm handoff from a crisis response to the next level of care and do follow-up post-crisis is really key to engagement strategies, but also having the real-time access and knowing exactly what the needs of the individual are being able to engage them at the level of care that they need, and being able to initiate treatment during crisis, including use of medication if it's appropriate and accessible, is going to improve engagement strategies. So I really think that real-time availability, use of medication if appropriate, and connection through peers with follow-up post-crisis increases engagement levels.
Great, thank you. Thank you, Rebecca.
Hey, Val, can I just go back quickly?
Sure.
Yeah, just one thing to add on the youth homelessness piece. You know, in many communities across the country, there's a growing number of youth self-advocates and programs that exist out there. You know, when we talk about bringing people with lived experience into our crisis programs in staff or, adjunct type of support, there are individuals who are sort of in that, 18, 19, 22, 23-year-old range who have lived experience with mental illness, substance use disorders, homelessness, who you can incorporate into your peer living strategies in your crisis programs as well.
Right. Yes, good point. Thank you. And the peer workforce really has been shown to be really critically important in this space. So thank you. Also, I'd like to call on Neerja Singh. Apparently in Minnesota, they have an initiative that uses Medicaid funding to help individuals who are homeless. I just want to give you a moment, Neerja, just to share a little bit briefly about your program.
Hello, this is Neerja. Thank you, Valerie. So we just initiated a Medicaid benefit, which is called Housing Stabilization Services in July of 2020. And it's a brand new Medicaid benefit for people with disabilities, including mental health and substance use disorders. And also, like, it specifically targets our seniors who are on the verge of, who are currently either homeless or on the verge of being homeless. In addition, we have also a special benefit for people with mental health and substance use disorders who are living in institutions or other settings and who are at risk of experiencing homelessness when they leave. So the goal is to support their transition into housing, and which will be now Medicaid funded, which is awesome. And the other is to increase long-term stability in housing and the community, and to mitigate risks for future experiencing future homelessness. One thing that is important about this service to know is that we have tried to make it really easier for clients to get the eligibility documentation completed. Because for most of our other programs, it's like you've got to have a diagnostic assessment, and it's hard to when you are living on the street, it's hard to get you connected with a mental health or a substance use professional who can do it. So for this service, it is really a simple document that needs to be completed, and it can be completed by the care coordinator. So you really do not need a mental health professional to be completed it. And given the workforce shortage in Minnesota, we thought that this is very important. We will be gathering data starting July, which is this month, and hopefully we'll have some positive outcomes on this service. This service involves development of an individualized housing support plan, identifying like all the obstacles, including untreated mental health and substance use disorder as an obstacle that can raise a person's susceptibility to be homeless. And then supporting the clients to negotiate a lease, identifying resources to cover moving expenses, and then connecting them while they are in the new setting, connecting them with aftercare resources to make sure that this is like sustainable in the long run. So that's all we have. I think I have one pager that I can send to Valerie, and if you want to share with others, that'd be great. So yep, I will send it to you right now, Valerie. And then besides that, we do have mobile crisis services, where we do serve clients who are having crisis as related to their substance use disorder. However, as compared to mental health, our substance use disorder teams are limited in their scope and training. So that's what the state grants are going to be targeting this coming 2021 round, that we will be like bringing more parity. And I was listening to Rebecca talking about recovery peers. And that's really what we want to do. We want to have all our crisis team incorporate a peer, whether it's a mental health peer or a recovery peer. And on top of it, we also want to create more family peer specialists in Minnesota, especially to serve families with children with mental illness. So we are in the process of creating curriculums and trainings for our family peer specialists. We don't have a lot of those. So that way we'll have like the whole integrated approach at one end. So with that, I can take questions.
Great, thank you, Nirja. So we're really at the end of our time now, but actually if you would send that information on to Megan Hopp, then she can forward it on to the individuals who are on this call, and then they can follow up with yourself or whoever the contact is.
They can follow up with me
to get additional information. Great.
Yes.
Thank you very much for sharing
Thank
that.
you, Valerie. Yeah. Bye-bye.
And so we've come to our time, but I want to give Kevin and Rebecca a half minute or so to just to wrap up. Is there anything else that you want to share with the group before we move on? That'd be great.
Rebecca, you want to go?
I'll just say thank you for the opportunity, and it's really exciting to see the support of NASHPID and SAMHSA in moving forward with crisis response as it relates to substance use disorders. And I'm just really great to have the discussion.
Thank you.
Yeah, and I would echo that. Thank you for the opportunity. This is a tremendous issue, and we do work all over the country, and we get to see what's going on in many of your states, and crisis programs are all over the place, and we've got a large challenge in front of us to really get them in place. With all these components that are mentioned in the SAMHSA guidelines. So you all have a heavy lift in front of you, particularly in a really tough economic time going forward over the next couple of years, given the pandemic. I don't envy you. It is going to be a challenge. And I think just sort of the key takeaway here was, as you're hopefully standing up these programs, is to keep in mind, and this is oftentimes beyond your control, but just the state budgets and state budget cuts that we may all be experiencing going forward. If more and more people come into the system and less people have access to, those core services, our crisis programs are really going to be potentially overrun, and we have to really consider that going forward. But I really appreciate being here, and good luck with everything. It's good to see you guys.
Great. Thank you both so very much. It's great to hear that there's life after being a commissioner, and we just so much appreciate all of the contributions that you continue to make, even beyond that. Your presentation was really very engaging and very much appreciated. So thank you both very much.
Thank you.